Fluid and electrolyte, the process of regulating extracellular fluid volume, body fluid osmolarity, and plasma concentrations of electrolytes. Fluid is water plus the substance is dissolved and suspended in it. Electrolytes are substances that are charged particles, ions, when placed in water, cations and anions. Osmolarity, degree of concentration, diagnose diabetes insipidus, helps us look at hydration status. We look at both urine and serum osmolality to assess how well the kidneys are concentrating the urine, balance of water and sodium, person is dehydrated or if they have fluid overload. Oliguria, urine output less than 0.5 milliliters per kilogram per hour, less than 400 milliliters in 24 hours. Anuria, decreased urine output of less than 50 milliliters in 24 hours. Polyuria, excessive urine production, 2.5 to 3 liters of urine in a whole 24 hour. Normal is urine output will put out 1 to 2 liters a day. Dysuria, painful or difficult urination. Hematuria, red blood cells in the urine. Renal clearance, ability of the kidneys to clear solutes from the plasma. If a person has a low renal clearance, it means that these solutes are not being cleared by the kidney, so they're backing up into the patient's system. Help to convert vitamin D to its active form for calcium absorption. Risk factors for impaired elimination. Non-modifiable. Modifiable, can change by prevention education or could even be with medication. Age, infant versus older. Confused, unable to communicate. Elderly clients have a decreased sensation of thirst. Vomiting or diarrhea is at a high risk for fluid in electrolyte imbalance. Nocturia, so that's urinating at night time, they have increased urinary frequency. Sometimes they are not able to fully empty their bladder, so they'll have urine stasis, which could lead to infection. Age, the ability to get to a bathroom could be decreased, and so that could cause a person to not go to the bathroom as much or to be incontinent. Ethnicity. Genetics. Heart disease, HTN, CAD, HF. Hypertension. High blood pressure can actually damage the small blood vessels in the kidneys. When this happens, the kidneys aren't able to filter as well as they should. Kidney disease can cause high blood pressure because the kidneys aren't able to filter out all that water and salt. Heart failure. Having to take diuretics, so this will cause fluid imbalances as well. Coronary artery disease. DM, diabetes mellitus. Nephropathy is kidney damage that's caused by diabetes. It's related to damage that's done from high glucose levels. Unhealthy lifestyle. Diet. Exercise. Smoking. Excessive ETOH intake. Major trauma/surgery. Major trauma or surgery, so you want to think of your hypovolemic patient. Stress. Pharmacological. Diagnostic testing. Urinalysis looks for protein in the urine, looks for red blood cells in the urine, looks for glucose/urine culture. Red blood cells can be caused by glomerular dysfunction part of the kidney, and we can also look for white blood cells as well, which will tell us if there's any inflammation. Urine specific gravity, normal, 1.010 to 1.025. Urine osmolality, normal, 250 to 900 mosm/kg/24 hr. Renal function tests, kidney, ureter and bladder, KUB. Studies helps us to look if there's any type of blockage, any type of calculi or stones helps us look at the kidney size and any sort of masses, kidney US, bladder US, altered elimination to see if they have any urinary stasis, so you'll often see these done after our patient has a Foley catheter removed and if they haven't urinated a specific time. We want to see how much urine is still in their bladder, or when they do urinate we want to see if they have any urine still in their bladder post-void, so this is done at the bedside. CT, MRI, nuclear scans. Cystography uses contrast dye. After this catheter is placed, the patient may have some blood in their urine for about 24 hours, but we want to make sure it stops, and we want to make sure it's not excessive. We're going to look for bright red blood or cloths, and we're going to also look for the ability to avoid after this is done, because the catheter is introduced. We want to look for infection. We want to make sure that they remove all of that they're able to urinate all of the kidney the dye that was used so it doesn't damage the kidney. Cystography is an imaging test that can help diagnose problems in your bladder. It uses X-rays. Renal angiography uses dye, which is nephrotoxic. Check shellfish allergy *. Make sure the patient has good fluid intake after flushing out the dye. INO, femoral or brachial artery, monitor for bleeding, bed rest, monitor VS, and site frequently. Check pedal pulses and CSM. Monitor their creatinine level. So that's that renal function test. It's gonna tell us how well their kidneys are functioning. If it's high, which most of the time it will be, when somebody has kidney damage, we want to make sure it doesn't increase. May possibly need to be NPO before the test, and after it's done we want to encourage that dye to be eliminated. So we'll either encourage peel fluids and make sure that we document that, or somebody may even have some IV fluid running. We'll get a baseline. And we want to make sure that they're not getting worse, specifically when we give dye. Acid-base component. Normal range. pH. 7.35 to 7.45. PACO 2. 35 to 45. POW 2. 80 to 100. HCO 3. 22 to 26. Electrolyte. Normal range. Potassium. 3.5 to 5.5 milliequivalent/L high. Magnesium. 1.8 to 3.0 mg/dL high. Sodium. 135 to 145 milliequivalent/L low. Chloride. 95 to 105 milliequivalent/L low. Calcium. 9 to 11 mg/dL low. Phosphate. 2.5 to 4.5 mg/dL high. Kidney labs. Normal range. Blood urea nitrogen. 5 to 25 mg/dL. Creatinine. 0.5 to 1.5 mg/dL. Glomerular filtration rate, GFR. Greater than 60. Creatinine clearance. 24-hour urine specimen. 85 to 135 ml/min. Urine osmolality. 24-hour urine specimen. 250 to 900 mosm/kg. Urine specific gravity. 1.005 to 1.030 low. It indicates that the urine is very dilute and that the person is actually possibly diuresing a lot, so that polyuria, when the number is high, a high specific gravity, indicates dehydration. Creatinine clearance test uses the 24-hour urine and also uses a serum creatinine levels, and that's what gives us the glomerular filtration rate, the GFR. When it's ordered, we're going to start it after the patient voids, and they're going to discard the first specimen for the next 24 hours. There, all the urine is going to be collected in a container that's typically on ice or in the refrigerator. If they're home, we want to make sure that we label the container with the time of the collection, the date, the patient's name, and if a person has polyuria, we're going to want to make sure that we number the containers, because they could have more than one. So all of the area must go into this container, and we want to document the INO to make sure that it's accurate. So let's say we start the test at 7 a.m. We have the patient void and discard their first urine. The reason of that is because the bladder's been sitting, the urine has been sitting in the hyperkalemia S/S greater than 5.5. Weakness. N/V/D. Confusion. Dysrhythmias, tall peaked T waves, widened QRS. Hypotension. Oliguria. Restlessness. Paresthesia. Muscle cramps. TX, diuretic, loops. Insulin and glucose. Calcium gluconate, does not decrease K. Sodium polystyrene sulfonate, Kxalate, diarrhea to excrete. Sodium bicarbonate. Hemodialysis. Monitor INOS. Intravenous calcium is effective in reversing electrocardiographic changes and reducing the risk of arrhythmias, but does not lower serum potassium. You can develop muscle fatigue or muscle weakness due to high potassium levels. Simple activities like walking can make you feel weak. Your muscles may also lose their ability to function properly, resulting in exhaustion. You may even experience a dull, continuous ache in your muscles. Hypocalcemia S/S, less than 8.5. Twitching, tingling, or twitching or cramping. Paresthesia, fingers, toes, around mouth, tingling around the mouth or the lips muscle. Positive Trousseau's sign, cheek twitch, when somebody taps on that facial nerve. Positive Trousseau's sign, elbow flexes, by inflating BP cuff. Positive Trousseau sign, which is a spasm of the wrist. Seizures, seizure precautions. Seizure pads at the bedside, want them all padded. We want the bed rails raised, because they're padded, and to keep them safe make sure suction is available in the room, and make sure that we have IV diazepam or Dilantin available. TX, daily dose of calcium carbonate, severe low calcium, PO, and 4 calcium gluconate or calcium chloride. Foods high in Ca. For calcitonin if severe. Calcium chloride for differentiate between slow/low calcium carbonate versus severe/fast calcium gluconate and calcium chloride. Hypocalcemia, so some signs and symptoms of it are tingling around the mouth or the lips muscle, tingling or twitching or cramping. They have a positive Trousseau's sign, which is technically of the muscle at the cheek, when somebody taps on that facial nerve. Thoughts of positive Trousseau sign, which is a spasm of the wrist that's induced by pressure, so typically we'll test that by inflating a blood pressure cuff. And we'll see that they have spasm of their wrist. Patients who have hypocalcemia are at risk of seizures, so make sure that we follow seizure precautions. Seizure pads at the bedside, want them all padded. We want the bed rails raised, because they're padded, and to keep them safe make sure suction is available in the room, and make sure that we have IV diazepam or dilated available. We treat hypocalcemia. Again, will have that daily dose of calcium carbonate, but if a patient has severe low calcium, we're going to give them PO calcium gluconate or calcium chloride for calcium gluconate, so not all calciums act the same, so you'll want to make sure you differentiate between that calcium carbonate versus calcium gluconate and calcium chloride. Kidney functions. Urine formation. Excretion of waste products. Regulation of electrolytes. Regulation of acid-base balance. Control of water balance. Control of BP. Renal clearance. Regulation of RBC production. Synthesis of VIT. D to active form. Secretion of prostaglandins. The prostaglandins are a group of lipids made at sites of tissue damage or infection that are involved in dealing with injury and illness. They control processes such as inflammation, blood flow, the formation of blood clots, and the induction of labor. Exemplar, acute kidney injury, rapid decline in kidney function with azotemia, increased levels of nitrogenous waste in the blood, rapid accumulation of toxic nitrogen-containing waste products such as urea and creatinine in the blood, fluid and electrolyte imbalances and acid-base imbalances. AKI is usually reversible. Causes, commonly caused by ischemia, cardiogenic shock. If they have sepsis, they have low volume that's causing ischemia, not enough nutrients and oxygen getting to the kidneys. Nephrotoxicity, nephrotoxins. So many medications are toxic to the kidneys, so you have your NSAID, you have some aminoglycoside antibiotics, so those usually end in mycin. So like your gentamicin, your patients receiving any type of antibiotic that ends in mycin. And you want to make sure that you're paying attention to their kidney function. Other nephrotoxic agents can be those ACE inhibitors I talked about, although sometimes when it's first used it can be protective to the kidney injury, infections, major surgery, or tumors. 1. Prerenal, above, decreased blood volume or oxygen/nutrients to kidneys. Hemorrhage. Shock. Dehydration. Cardiac failure. 2. Intrarenal, in, something that happens directly to the kidneys. Acute glomerulonephritis, caused by strep B. Nephrotoxic drugs, NSAIDs, mycin antibiotics, ACE inhibitors, chemo. Sepsis. Contrast dye. 3. Post-renal, below, an obstruction where stuff can't get out the kidneys. BPH. Renal calculi. Fecal impaction. Clinical manifestations of AKI. Low GFR less than 60. Increased BUN, CR. Oliguria. Azotemia is an elevation of blood urea nitrogen, BUN, and serum creatinine levels. Fluid retention, FVE. Electrolyte imbalances. Neuromuscular abnormalities are /T electrolyte imbalances. Metabolic acidosis, low. Anemia. Confusion. Possible seizures. Anorexia. N/V. Phases of AKI. 1. Initial, the onset of AKI. 2. Oliguria, less than 400 in 24 hours. Waste is building up, BUN, CR rising, hyperkalemia, increased electrolytes, FVE, fluid volume excess with pulmonary edema, possibly heart failure, low. 3. Diuresis, improvement, start putting out fluid and working again. A lot of urine, risk for FVD, decreased electrolytes, low BUN and CR, GFR would go up, kidney can filter more now. 4. Recovery, can take up to a year. Treatments. Treat underlying cause. Maintain fluid balance. Possible renal replacement therapy, I.E., dialysis. Treat electrolyte imbalances, hyperkalemia. Maintain acid-base balance. Nutritional support, individualized to meet clients' needs. Remember, high potassium manifest as neuromuscular dysfunction, so we're going to see some muscle weakness, other symptoms of hyperkalemia, and nausea or vomiting, diarrhea, but more specifically on an ECG, we'll see specific changes. We'll see the T wave VATs at the end of the electrical rhythm become tall and peaked, so tall peaked T waves. We could also see the QRS become wider. When this happens, the patient is at high risk of cardiac arrest, so we're going to want to make sure that we're putting some things into place. Follow a low potassium diet. That would be number 1. That's something we can change right away. If we see that the potassium is creeping up, we might want to give a patient some K-exolate. So when we give a patient K-exolate, it's an enema that can absorb the potassium and then pass it in the stool. However, if we see potassium levels really high, we see those tall peak T waves, we see some confusion with the patient, we see some muscle weakness, we're going to want to treat it immediately. So some medications that we can give in an emergency is for glucose. So we'll give AD50 then to combat that. When the glucose goes up, we need to give some regular insulin. We could also give for calcium gluconate or for sodium bicarb. And what these do, they drive the potassium back into the cells, so we won't have hyperkalemia. However, they're just temporary, so again, we'll want to continue tomorrow to them, possibly then continue to give them K-exolate, and even possibly stop them on dialysis. But remember, there's something that we need to do immediately. High potassium, neuromuscular dysfunction, muscle weakness, nausea or vomiting, diarrhea, ECG, tall peaked T waves, QRS become wider, high risk of cardiac arrest. Low potassium diet, K-exolate, it's an enema, absorb the potassium and then pass it in the stool immediately. For glucose, D50, regular insulin. For calcium gluconate or for sodium bicarb, sodium bicarbonate. Sodium bicarbonate works to shift potassium intracellularly, but is not considered first-line management of hyperkalemia. Drive the potassium back into the cells. For calcium gluconate in patients with a hyperkalemic emergency. If ECG changes present and or serum potassium greater than 6.5 milliequivalent/L, give calcium gluconate 1000 milligrams, 10 milliliters of 10% solution, or calcium chloride 500 to 1000 milligrams for over 2 to 3 minutes to stabilize cardiac membranes. Nursing care. Monitor FNE. Skin care. Reduce metabolic rate. Reduced metabolic rate, so their energy is going where it needs. Bed rest decreases metabolic rate. Promote pulmonary function. Prevent infection. Psychosocial support. Acute kidney injury is reversible, but we just have to really make sure that we keep a close eye on them, so when acute kidney injury does not resolve, we end up with chronic kidney disease. Daily weight gain. So remember that 1 kilogram of weight equals 1 liter of fluid. Fluid restriction is less than 2 liters of fluid a day. A more strict fluid restriction would be a 1.5 liters per day, but it all depends on what we're doing with the patient and what our goal is. But know that a fluid restriction is 2 liters or less a day. Loop or osmotic diuretics. So some loop diuretics have bumetanide, bumex, or furosemide. Osmotic diuretics or mannitol. She works by increasing the secretion of electrolytes potassium, sodium chloride, magnesium, and wastes like urea. However, if we're going to give a patient mannitol, there's some things that we want to think about. What type of patients that we not going to give this patient this medication to. So remember, your heart failure patients should not receive man at all because this drug increases vascular volume, which could then cause exacerbation of heart failure. We also want to think about what types of diuretics are going to be inappropriate for this patient. So remember, during acute kidney injury, they are at high risk of high potassium, so we want to actually avoid those potassium-sparing diuretics like spironolactone, because that's going to actually increase their potassium. No high in protein, high in phosphorus, no red meat, too much protein and breaks down into ammonia. High in potassium, because we don't want them to have too many of them. AKI oliguria, low urine specific gravity. Exemplar, chronic kidney disease, kidney damage, or decrease in glomerular filtration rate.